Good afternoon, everyone. My name is David Connell. I'm not Tom Farden. I'm his roommate, however, and also one of the other chess consultants, and Tom is delayed. So I said that I would introduce Grand Rounds on his behalf today, and it's a delight to welcome Dr. Sarah Alstaff, who's one of our colleagues as a consultant in GU Medicine and clinical lead for HIV, who's come up with the absolutely brilliant title of Clap for the NHS, a post-COVID lockdown gonorrhea outbreak. So, oh, I can see Tom. There he is. He's waving. He's in a car. Keep your eyes on the road, mate. And
I've stopped.
Right,
it's all right.
Stopped. Good, right. So I've done my duty. I've introduced Sarah. Sarah, take it away.
Lovely. Thanks very much, and thanks everyone for coming in. So yeah, without further ado, this is Clap for the NHS. So just a little bit about clap. Oh no, now why won't this move forward? Hang on. Oh, here we go. So the clap is a term colloquially used to describe gonorrhea. Where did it come from? Well, some of the various theories do speak to a bit about gonorrhea. So the first term was le clapier, which speaks to the transmission of gonorrhea. Le clapier is French, I think, for rabbit hutches. And this was the style of accommodation in medieval era Parisian brothel district, which was then known as le clapier. And so there is a school of thought that the clap came from there. Clappen is an old English word I understand, which means to beat or to throb, and speaks to the symptoms of gonorrhea, although I probably wouldn't have listed them high on the list of symptoms, but however, that is one theory. And another theory being to clap, and actually an old treatment for gonorrhea was with the hands, with perhaps books or even paddles to forcibly emit infected secretions from the penis with a great big clap. So those are theories as to why we might call gonorrhea the clap, but of course no definition is complete without referring to the Urban Dictionary, and the only definition I could come up with that I could choose that was appropriate and also accurate was this one: a sexually transmitted disease that's medical name is very hard to spell. And this is my phrase, the hysteria. Gonorrhea has been documented in ancient texts and was also written about in the Old Testament when Moses and Aaron were instructed to speak to the Israelites and say to them, when any man has an unusual bodily discharge, such a discharge is unclean. Whether it continues flowing from his body or is blocked, it will make him unclean. And actually the whole chapter, chapter 15 of Leviticus, goes on to talk about all manner of bodily discharges, both for men and women, and what you should do about them. Hippocrates described a syndrome called strangury, which was thought to be gonorrhea, which had been understood to be to occur as a result of the pleasures of Venus. And finally, Galen, the Greek physician, is the one who coined the term gonorrhea, gono meaning seed and rhea meaning flow. And that is where the word gonorrhea has come from. And of course, gonorrhea has been widely documented, particularly in relation to war over the years. In 100 to 40 BC, it was documented in Roman soldiers fighting Julius Caesar. In World War I, although we think trench foot is the sort of the malady of World War I, actually you were 5 times more likely to be hospitalized with VD, i.e. gonorrhea or syphilis, than with trench foot in World War I. And there were about 400,000 UK hospital admissions with that in World War I. And around that time is when the UK introduced the Venereal Disease Act, which stated that local authorities were to fund and provide confidential clinics that were free, that were provided by qualified specialists, that also addressed the public health need as in partner notification. And so this obviously predated the NHS. And it was based on this that gum came to be a specialty, although it was known as venereology back then. And actually the UK is the only nation in the world that that has gum as a specialty, that gum doesn't exist as a specialty out with the UK, except perhaps Australia and New Zealand. So yeah, the reason that we do the clinics the way we do them all stems back to the Venereal Disease Act. And it was during World War II that you started to get sort of public health awareness campaigns around STIs. And there are many examples of these from World War II. And so just looking at the epidemiology over the last century or so, you can see after World War I, there was a bit of a dip. The top line is in men and the bottom line in women there. And then another peak around the time of the end of World War II. It didn't last long. The swinging 60s and free-living 70s resulted in further increases in gonorrhea, alongside the availability of oral contraception and the decriminalization of homosexuality. But of course, in the mid-80s, STI rates really dropped when people's behavior changed on the back of the emergence of HIV and AIDS. And that kept levels of most STIs suppressed for some time. But what we've seen now, all these camera bits are in my way, I can't see. What we can see now is huge increases in gonorrhea rates. And by 2019, just before we had COVID, we were seeing more gonorrhea than we had really in recorded history. So unprecedented levels of gonorrhea in the UK. And this is mimicked in other Western countries, for example, the United States. So we can see that there are a number of contributors to STI outbreaks. It's not just a matter of individual behavior. There are systemic factors, social and economic instability, mobilization and repatriation of people, the cultural landscape in which sex is happening, structural things, for example, access to services, testing technology, frequency of testing. There are, of course, biologic factors, infectivity, virulence, emergence of new strains, and of course, individual behavior. But I don't think that based on the social and economic instability over the last few years, access to services, access to testing being interrupted, that a gonorrhea outbreak was predicted when we were coming out of lockdowns. And gonorrhea didn't fail. And so we have seen, again, we've picked up where we left off at the end of 2019, and we have continued to run with that ball. And so this is Scottish data back from 2019 up to 2022. Tayside is the red line, the big boys up there, Lothian and Greater Glasgow and Clyde. And this is incidence of gonorrhea, and we are up there with the big boys. So the highest incidence of gonorrhea in Scotland. The rest of Scotland sitting about half of what we have in Tayside. I'm just looking at Tayside data specifically from 2019 to 2022. This is by month. So in the pre-COVID era, obviously chlamydia was our predominant STI, and gonorrhea, we were seeing maybe up to 30 cases a month or so. Following the first lockdown, there was a decline, and again around the second lockdown. But if we take just the red bars, you can see that we have continued to rise and are now seeing, well, this is June 2022. I can assure you it continued to rise. We've actually peaked, I think it was November 2022, at 74 cases of gonorrhea per month. So we've never seen anything like that in Tayside before. And so more than doubling of cases between 2018 and 2022. And just flashing back to 2011, I had just started as a consultant here in 2010, and we were dealing with our first outbreak of gonorrhea at that time. And you can see that at most we were seeing sort of 20 cases a month. So that really puts it into perspective. We called an incident management team at that stage in 2011 because of this rate of gonorrhea, when usually we might expect to see 5 cases a month. So put that into perspective, and we've been seeing 74 per month in recent months. So we're going to go on to talk a little bit about gonorrhea, all the different things that you might expect that we might speak about. So epidemiology and transmission. So you probably know that gonorrhea is caused by the gram-negative bacterium, Neisseria gonorrhoeae, that grows in pairs. It appears as gram-negative diplococci, usually intracellular within the polymorphonuclear lymphocytes. Very similar to Neisseria gonorrhoea, but lacks the virulence associated with the polysaccharide capsid of meningococcus. And the gonococcus affects the squamocolumnar epithelia. So primarily infection takes place in the distal urethra, the endocervix, conjunctivae, the rectum, and the oropharynx. How does transmission take place? Well, genital contact, so largely through infected secretions. Orogenital contact, particularly where the penis is in close proximity to the throat, because it's pharyngeal carriage, so it's more likely through fellatio than cunnilingus. Oroanal contact. Also, there's probably a thing about infected saliva being used as a lubricant also for digital anal contact. Gonorrhea can be transmitted on fomites, so we do recommend when people are sharing sex toys that they do use condoms for them. And there's actually really interesting emerging evidence. There's a group in Melbourne, Eric Chow and Kit Fairley, who've done some work on the role of kissing in gonorrhea transmission, and it seems to promote gonorrhea transmission, but not chlamydia. And it's been demonstrated that it's associated with higher rates of gonorrhea in sex between men and sex between men and women. They looked at groups who had where sex happened with kissing and sex happened without kissing, and there was more gonorrhea where sex happens with kissing. And that they also showed that there was a difference where hookups were made on apps. There was more likely to be kissing, more likely to be gonorrhea, whereas in sex on site venues, there was less likely to be kissing and less likely to be gonorrhea. I didn't provide the references and I'm very sorry about it. Students, do not take note of that. So transmission. From infected female to male. So if you have sex with a female, if you're male and have sex with a female who has gonorrhea, there's a 20% risk that you will acquire the infection. However, if you are female and have sex with an infected male, you're far more likely to acquire gonorrhea. And that's because of the volume of fluid that's transferred during sex and that retention of infected secretions within the vagina for a longer period of time. But one of the main factors in transmission of gonorrhea is the asymptomatic carriage rate. So 50% of women who have gonorrhea do not have symptoms, and 20% of heterosexual men will not have symptoms, and therefore that fuels onward transmission because behavior change has not been amended. Looking at some of the UK data, putting gonorrhea into perspective, this is amongst men over the last decade. We're looking at the grey line here. So over the last decade, gonorrhea has increased. We know that, we just discussed it. Genital warts has come down fairly gradually in men. Vaccination hasn't really been introduced until the last couple of years, and so that's an indirect benefit from the girls being vaccinated at school. Syphilis, again, a climb there. I don't know why they chose these particular STIs to compare gonorrhea to, but here we are. And this is women. So again, a decline in genital warts and a rise in gonorrhea, but not at the same level. And that's because of transmission. That gonorrhea is more likely to affect men because of the high rates of gonorrhea in men who have sex with men. All right, so men may be less likely to acquire it from women. There's a high transmission rate between men. Again, looking at sexual orientation here. So gay and bisexual MSM account for the largest proportion of gonorrhea in the UK. In terms of age ranges, STIs are generally more common in the under 25s. That's reflected here in this peak in women, and that follows the same rates of chlamydia. Whereas in men, they're at higher risk up until really forever. No, they're more likely to acquire infections into their 30s and 40s. Looking at ethnic groups, we know in developed countries that STIs are more common in non-white ethnicities, and that's shown here in men. We're looking at this checkerboard here that we can see compared to white men, we're more likely to find gonorrhea in non-white people, and the same is true in women, although at a lower rate. Just looking at the Tayside outbreak, we don't have a lot of granular data because we have relatively small numbers. But what we saw over the most recent outbreak in 2022-23 is that it was initially driven through gay and bisexual MSM, but actually what we're seeing now is largely heterosexual transmissions, particularly in the 16 to 25 age group. Looking in 2019 here, we can see actually the majority of our gonorrhea was in Perth and Kinross. I don't know if that was a fluke, but there we have it. However, you can see that the green line shows that this outbreak has mostly been within Dundee City. Of note, just over a quarter of gonorrhea infections are accompanied by chlamydia. So the clinical features of gonorrhea, I was going to use a case. This is a real case that presented, I can't remember if it was 2021. It was 2021, I think. I've called her Melissa. She is a 22-year-old cisgendered female who on day one had presented to A&E with right knee pain and was given analgesia. She returned, I think she was also referred to an orthopedic outpatient appointment that she was yet to attend, but in the meantime, on day 4, she reattended A&E and seen by orthopedics there. Her knee was further swollen. She had a temperature. Examination showed a tense effusion, particularly affecting the suprapatellar pouch. She had a raised CRP. They did a joint aspirate. They didn't see any organisms, but they had noted that she had had chlamydia in the past, and they thought that she might have reactive arthritis, and they gave her doxycycline. Her GP had repeated the chlamydia and gonorrhea swab, which came back a couple of days later with both chlamydia and gonorrhea positive. Now, sexual health are copied into all gonorrhea results, just so that we can keep an eye that make sure that they've been treated. And so this passed the desk of our sexual health admin assistant, and they're very, very good here. Our admin assistant saw the result, saw in the clinical details that it said knee pain, and she thought actually that could be gonorrhea and that needs dealt with. So that came to us at about 4 p.m. one afternoon. Of course it did. So eventually we managed to get her into clinic in the evening. At that stage, she was unable to weight bear. She had reduced appetite. She complained of chills. She had a 1-month history of a change in vaginal discharge. She had postcoital bleeding, and she had pelvic pain. No eye symptoms, skin symptoms, or other joints involved. Her last sexual contact was 2 weeks previously with a regular male partner of 1 year with whom she sometimes uses condoms. She last had sex with a different person 2 months ago, or 2 months previously, I should say. Another regular male partner over a 2-week period with whom she used no condoms. She has an interesting past history of emotionally unstable personality disorder, and she'd actually been admitted following an accidental overdose of both prescribed and non-prescribed drugs. I'm going to say about 2 weeks before this presentation. She has a history of being sexually assaulted on more than one occasion. She took the progesterone-only pill as contraception, and there were no other high risk factors for bloodborne virus. So on examination, she had a fairly normal temperature. She was tachycardic. She had marked swelling of her right knee with very limited range of movement. And I was unable to position her on our couch for a pelvic examination given her pelvic symptoms. So we did a pregnancy test, which was negative. I did a blind vaginal swab for gonorrhea culture. We'll go on to talk about that. We already know that gonorrhea and chlamydia were isolated from a genital swab. I did throat swabs because anybody with gonorrhea, we would do throat swabs to look for the infection in order to check that it's gone. A test I call gonorrhea a few weeks later. Yeah, I mostly amuse myself. So the plan was to admit her for the usual bloods, the usual care, a therapeutic knee aspiration. Treatment for gonorrhea is ceftriaxone. The plan was 1 gram daily for up to 7 days, and I wanted to add an empiric treatment for pelvic inflammatory disease with doxycycline and metronidazole, given she had 2 infections and a whole host of pelvic symptoms. So on her bloods, her CRP had now climbed to 203 from 77. Her BBV screen was negative. Her throat swabs were negative, as was her vulvovaginal gonococcal culture. Now, she was on doxycycline for about 3 days when these cultures were obtained. About 30 mils of turbid fluid was aspirated from her right knee. The gram stain was negative, the gonococcal culture was negative. However, the lab did a NAAT test, a nucleic acid amplification test, which was positive. We'll go on to talk about that. And actually, we also tested the sample taken in A&E days before, which was also positive for gonorrhea NAAT. So she completed IV ceftriaxone. She stayed in for a couple of days and she had OPAT to complete the 7 days of IV ceftriaxone. She completed 2 weeks of doxycycline and metronidazole, and we were able to do partner notification while she was an inpatient. Unfortunately, she did not attend for any follow-up, didn't answer phone or text messages. She didn't attend for a test of cure, and it may come as no surprise to find that over the last year, she's had 2 further episodes of chlamydia. So just looking at the general symptoms of gonorrhea, what we've not caught in Melissa's case. So gonorrhea affects the urethra, causing urethritis. So a urethral discharge, which is often mucopurulent, and dysuria in the absence of other urinary symptoms. So you don't get the bladder upset symptoms like frequency, nocturia, etc. You might get a bit of urgency due to urethral irritation. Complication is epididymoorchitis, and in the pre-antibiotic era, that occurred in about 20% of people with penile urethral urethritis and gonorrhea. Proctitis, so in gay and bisexual men who have sex with men, we see proctitis. It's often, again, a mucopurulent proctitis with rectal discharge. They may get some bleeding, irritation, they may get tenesmus. In our outpatient clinic, we do proctoscopy. We can obtain samples that way. And any STI in the context, if you have HIV, that is not treated and you have an STI, there is upregulation of viral replication and an increased risk of transmission on. Furthermore, if you have rectal gonorrhea and you are HIV negative, but you come into contact with HIV at the rectal site, gonorrhea, the inflammatory response associated with the rectal STI will enhance the acquisition of HIV. And just going back to that, actually, if you take chlamydia, for example, men who have rectal chlamydia, the incident rate of HIV over the next year is 6%. So looking at female patients who are assigned female at birth, the endocervix is the site for infection, and that cervicitis can then cause a vaginal discharge, which is what some women will complain of. The cervicitis can also cause intermenstrual bleeding and postcoital bleeding. Females can also get urethritis, although it would be unusual to have a sole urethral infection. But women may complain of dysuria. Gonorrhea can infect a number of glands, Tyson's glands, skin glands, etc., but also Bartholin's, and can be responsible for Bartholin's abscesses. 10 to 20% of women will go on to get ascending infection causing pelvic inflammatory disease, which may manifest as a endometritis, salpingitis, or oophorytis. And we see an awful lot of women with pelvic pain in our sexual health clinics. Of course, women can also get proctitis, and they don't have to have receptive anal sex in order to get proctitis. You can get transperineal spread of infected secretions from the vagina, particularly overnight into the rectum. And of course, they also an increased susceptibility to HIV, although less likely to come into contact with HIV than GBMSM. Furthermore, gonorrhea can complicate pregnancies, causing a range of outcomes from early on in pregnancy with spontaneous abortion through to chorionitis, neonitis, premature rupture of membranes, premature delivery, and all of those resultant complications, ophthalmia neonatorum, which looks like a very miserable condition to have. Looking at extragenital gonorrhea, so pharyngeal infection is actually fairly common, usually asymptomatic, most common in gay and bisexual MSM in females, and a small proportion of heterosexual males with gonorrhea will have a pharyngeal infection as well. Gonorrhea can infect the conjunctivae. often by auto-inoculation from infected secretions, although you could receive infected secretions directly into your eyeball, but usually it's auto-inoculation. And again, the conjunctivitis is usually quite, compared to chlamydia, which is maybe just a bit of chemotaxis, a bit of crusting, a bit of irritation, gonorrhea is quite mucopurulent, quite inflammatory. You might get surrounding cellulitis. You often see the discharge sort of dripping down the face. My colleague Graham Leslie sees some of the most interesting presentations. He saw a primary cutaneous infection recently that he could probably tell you about. I can't recall the details. And he also saw infection of a congenitally patent median raphe duct recently as well. Again, he can tell you about that at length. Moving on from uncomplicated or less complicated infections to disseminated gonococcal infection, or DGI. And the most common syndrome would be the acute arthritis dermatitis syndrome. It happens in a small number of people with gonorrhea, and actually a recent review in California showed that in that particular, they looked at a number of thousands of cases. It was something like 0.24% of all gonorrhea presented with disseminated infection. In the skin, you might get pustular lesions. They're usually on an erythematous base affecting extremities. And they talk about, usually there'll be less than 30 lesions. The arthritis seems to start as an arthralgia, progressing to a tenosynovitis, and then arthritis with effusion. But it doesn't affect all people with disseminated gonococcal infection. It may affect the wrists, MCPs, ankles, and knees. You also get that classical septic monoarticular or oligoarticular arthritis in disseminated gonococcal infection. Again, about half of DGI would be this particular presentation, affecting knees mostly, followed by wrists, ankles, and elbows. In this particular condition, compared to the arthritis dermatitis syndrome, you're more likely to be able to culture gonorrhea from synovial fluid and the blood. Although I think bacteremia is very intermittent with disseminated gonococcal infection, so that I think limits the sensitivity of blood cultures. Risk factors. So women are more likely to get disseminated gonorrhea than men, and it's also more likely in the first 7 days of menses. If you have pharyngeal infection, it's more likely to disseminate. And during pregnancy or immunocompromise, I think complement deficiencies and systemic lupus erythematosus might predispose you to disseminated infection. DGI is often underdiagnosed, largely because I think it's assumed that you should have genital symptoms in order to have DGI, and the absence of urogenital symptoms may result in this going undiagnosed. There's a low pickup rate on blood cultures, and actually often negative cultures from joint aspirates, and I'm sure the microbiologist could tell you a little bit more, but I think the strains of gonorrhea that disseminate are less likely to grow on the particular culture media that we use in labs for gonorrhea. I'm sure there's some complicated science and stuff involved there. All right, so taking us on to the complicated stuff, it's not very complicated, diagnosis, or not my understanding of it anyway. So looking at how we diagnose gonorrhea. So this is like the old-fashioned way of doing it that we do absolutely every day here in the sexual health clinic. So if someone presents with a uterine discharge, we will sample that, we will apply it to a slide, we will gram stain it, and we will look at it there and then, and this is what we would expect to see. So we would see polymorphs. So these cells here with their different shaped multiple nuclei, and within the cytoplasm we can see these gram-negative diplococci. They're kind of kidney bean shaped, and you can see there's not other bacteria. You know, it's not like it's a mixed picture. This is quite a pure identification. And in a symptomatic patient, actually, we're about 95% sensitive in detecting gonorrhea. So it's a really great test, and it's done pretty much at the bedside. Unfortunately, detecting gonorrhea on a cervical smear is a lot less sensitive. We sometimes do, but usually not. Rectal smears, it's difficult with the sensitivity because of all the other organisms lying around, but sometimes when we do a proctoscopy and the rectum is otherwise pretty clean and you find a big lump of pus, you would sample that. We wouldn't do microscopy for a sample taken without proctoscopy, but yeah, we could sample a big blob of pus and do the same thing. Actually, we get a pretty good detection rate that way. So we would do microscopy. We don't do that for throat. We could probably do it at other sterile sites, for example, the conjunctiva. I haven't had to do that, I don't think. Culture. So culture is very specific for gonorrhea. However, it's not a very sensitive test for diagnosing gonorrhea. And we primarily do cultures in order to monitor for antimicrobial resistance. It's not the mainstay of diagnosis, but we do obtain samples from all sexually exposed sites where there's a high risk of gonorrhea. Based on clinical grounds, if someone has symptoms suggestive of gonorrhea, we would do cultures at all the relevant sites. So let's say they just had urethral discharge, but they were at risk of pharyngeal and rectal infection. I would do cultures at all 3 sites. We would also do cultures in people who are at a higher epidemiological risk of having gonorrhea, and that is largely immediate contacts of gonorrhea. If they're asymptomatic, we would still do cultures at all relevant sites. That's because if they fail treatment, we can go back to their antibiotic susceptibilities. And so the mainstay of gonorrhea and chlamydia diagnosis is NAAT, nucleic acid amplification test. We talk about NAATs in sexual health rather than PCR because actually the NAAT we use for gonorrhea and chlamydia is not PCR. And many of the diagnostic assays that we use are not PCR. Other examples include transcription-mediated amplification, which is the assay we're using at the moment in Tayside. Strand displacement amplification, ligase chain reactions are other NAAT tests that we use. So we tend to talk about NAATs, which I think confuses the students a little bit, but I don't want them to think that all NAATs are PCR. So NAAT tests are more than 95% sensitive at both symptomatic and non-symptomatic sites. However, the NAATs are all dual testing, so the NAAT, one swabble test for chlamydia and gonorrhea at every site. But the performance for both infections is different. So when you get a positive chlamydia, it's high specificity. However, for gonorrhea, not so much. There are false positives, and the specificity depends on which assay you're using, as well as, of course, the prevalence in the local population. And algorithms locally should result in a positive predictive value over 90%, and sometimes that includes using taking all positive samples and doing a NAAT on a different platform to detect a different target. We used to do that. I don't think we do anymore. So again, we would do a NAAT to detect the infection at the penile urethra. It's a first void urine, okay? So I tell patients to pee out all that nice discharge into this pot, and that's what we'll do a NAAT test on. The female genital tract, a self-collected vulvovaginal swab is the test of choice. It has the highest sensitivity. And we would swab the pharynx and rectum, and increasingly patients can do that themselves. NAAT tests are not validated at extragenital sites, but we do use them with a bit of caution. So just in summary, a dual chlamydia and gonorrhea NAAT at all relevant sites is the screening test and the diagnostic test, all right? And that's, you're going to pretty much guarantee detection. Gonorrhea culture, less sensitivity, but we do it for antimicrobial resistant, to monitor for resistance. We will gram stain and do microscopy if it's available at some sites. Blood cultures for if somebody has a disseminated gonococcal infection, of course, and tests for HIV and syphilis where any STI is present. So if you think somebody's got gonorrhea or is at risk of gonorrhea, do a full STI screen. If we hadn't done that on Melissa, we wouldn't have got it because she didn't engage in any follow-up, and that can be the case. So in terms of antimicrobial therapy, we do this to treat the patient. We also do it to prevent reinfection of the patient, so epidemiological treatment for sexual contacts. And the timescales that we look back depends on a number of factors, including their symptoms. So we treat the patient, we treat their partners to prevent reinfection, but also to prevent onward transmission. Within sexual health, we try to give single dose treatment that we can administer on site so that we know that it's been had. And we often administer before a diagnosis is confirmed. If you take urethritis where gonorrhea is negative, or where we hadn't seen gonorrhea, we presume it's chlamydia and we treat for chlamydia based on that. When it comes to treatment for gonorrhea, we do a test of cure, as I said, and I will repeat, a gonorrhea test. Okay, so here's where I talk about something I don't really fully understand, although I'm sure I've had to study it for exams, but antimicrobial resistance is the big thing in gonorrhea and lots of gram-negative bacteria. And gonorrhea, gonococcus has a high capacity for genetic mutations or plasmid exchange. The throat is probably an important site just because of the range of bacteria that are there. Globally, there's fairly unrestricted access to antimicrobials dispensed in communities where there are high rates of STIs, and that has contributed to antimicrobial resistance. Sulfonamides, I think, were the mainstay of treatment until penicillin became available in 1943. In the 1990s, we started using quinolones, and in the noughties, extended spectrum cephalosporins, although resistance to other antibiotics emerged over this period of time, despite us not really using them first line as gonorrhea treatment. And we moved from cefixime in the sort of early noughties through to ceftriaxone, which we've increased the dose over the years, and we now give a 1 gram stat dose of ceftriaxone. And I will thank Anna McDonald for the next couple of slides. This is from GRASP data. GRASP data is their sentinel sites across the UK where these data are collected, including Leeds, where I trained, where I spent many, many hours in the bowels of medical records pulling out gonorrhea reports. But this shows that the proportion of gonorrhea isolates that are resistant to various antimicrobials. You can see here that over the noughties, quinolone resistance had increased. We stopped using quinolones, gosh, I'm going to say in the late noughties. I'm sure around here we were already using cephalosporins for gonorrhea. You can see azithromycin, tetracycline resistance here, and azithromycin resistance really climbing and above that 5% threshold for first-line monotherapy. Ceftriaxone in the UK is still a safe bet. However, ceftriaxone resistance has been reported. I think there have been 3 or 4 cases in the last year. And so this has been our prescribing practice in the UK, ceftriaxone or cefixime or spectronamycin. Spectronamycin had really terrible penetration at the throat, which was its drawback. We used ceftriaxone and azithromycin for a number of years. Partly we thought it increased the bioavailability of ceftriaxone at the pharynx, but also because of the dual infection with chlamydia. But over the last couple of years, we've switched to using ceftriaxone monotherapy unless we know somebody also has chlamydia. So most people will get ceftriaxone monotherapy. And there we go, super-gonorrhea, ceftriaxone resistance emerging in certainly other cases across the world. I think it was only in the last month or 2 that the United States reported its first case. They're a little bit, their MICs for ceftriaxone have lagged behind ours. They've only just moved from 250 to 500 milligrams of ceftriaxone. And so what would we treat with in these cases? We would use potentially gentamicin with azithromycin. I think ertapenem has been used. There are drugs in the pipeline, but we can also, if we have antimicrobial resistance results available, we can potentially use quinolones, for example, if they are susceptible. So that's where we're at the moment. And finally, prevention. Look, I've got 20 minutes to spare. This is most unlike me. So prevention, right. Yawn, all the usual stuff, the stuff we know, condoms, okay, great. And they are excellent at preventing infections, but people don't want to use them. Some will, some don't want to. Regular testing is a great harm reduction intervention just to detect infection as quickly as possible, and then we can find other cases. Behavior change, reducing the frequency of partner change, reducing concurrency. Gonorrhea is more common in groups where there are denser sexual networks. So we know that increased frequency of partner change and the number of partners does influence gonorrhea transmission. So behavior change interventions. Unfortunately, although changing your behavior will help, us telling people to change their behavior isn't an intervention that works very well. And partner notification is also very important, but resourcing that is a challenge. So moving from the usual to the exciting. So just over the last few years, there has been a buzz about the use of doxycycline post-exposure prophylaxis against infections like chlamydia and syphilis. And there's been kind of conflicting views. I think there have been studies showing that doxycycline taken after sex does reduce the risk of chlamydia and syphilis. I think community groups are very keen to move forward with that, but medical groups are always worried about antimicrobial resistance and what harm can we do. A recent study within the US called DoxyPEP showed that taking 200 milligrams of doxycycline within 72 hours of an episode of sex reduces your risk of chlamydia and gonorrhea by 87% in HIV negative individuals and about 74% in HIV positive individuals. What they didn't expect to find was that gonorrhea would be reduced by 55% with doxycycline. And I just refer you back to that previous slide with very high levels of resistance, tetracycline resistance in gonorrhea isolates in the UK. And a French study called DoxyVac, this study was using doxycycline post-exposure prophylaxis, but they also added in the 4C-MenB vaccine to see if we could reduce gonorrhea rates. And they stopped, but when the results of the US study became available, they stopped recruiting, they analyzed their data and offered everybody doxycycline within the study because their results were almost identical, showing an 89% reduction in chlamydia and 79% syphilis with doxycycline alone. But without the impact of the 4C-MenB vax, gonorrhea had reduced by 51%. And actually, adding in the results of the vaccine, it independently reduced gonorrhea by 51%. And I understand the French study was done on men who have sex with men who were accessing HIV pre-exposure prophylaxis. And so this is some really exciting work. They did look as part of that study on the emergence of resistance within other bacteria, including Staph aureus, for example, and there were signals that there was a change in resistance. In terms of the impact of that remains to be seen. Of course, we use doxycycline for other post-exposure prophylaxis or pre-exposure prophylaxis, including malaria, quite liberally. So this, opens up a variety of opportunities, and we still, I think, need more data on the impact of doxycycline as PEP on the wider antimicrobial resistance, and also data in women, which is always lacking in sexual health. The 4C-MenB vaccine for gonorrhea is really interesting. What we don't know is how effective that is over time. I think in the study they were given 2 doses a month apart. But perhaps based on that and based on the similarities between meningococcus and gonococcus, perhaps a gonorrhea specific vaccine could be developed. But I think we also have to go back to basics, particularly in this COVID recovery era. There's a lot of basics that we need to get right. So within sexual health, we've had significant capacity issues trying to get back to our pre-COVID testing rates, although we're not doing badly, and we're currently performing at 92% of pre-COVID testing activity, which is remarkable given all the other stuff that we're actually having to undertake due to pressures in primary care. We're doing an awful lot more contraception, an awful lot more long-acting contraception, and that's applied pressure across our system. We are looking at a Scotland-wide online program for STI testing. So that again will help access to particularly asymptomatic testing that doesn't need seen by any clinician or service. But I do think that we need to continue to remember the importance of effective partner notification. So yeah, although there's a lot of exciting times ahead, we do need to get back to basics. In terms of awareness, as part of our response to the recent outbreak, our fabulous colleagues in public health developed an awareness campaign that was OMG, Oh My Gonorrhea, with a variety of sort of slogans. And so, so those had gone out to relevant networks to get STI testing. We put money into Terence Hagan's Trust, providing additional asymptomatic testing. As you might imagine, it's been difficult to do that via general practice, and also asymptomatic testing via sexual health has been a challenge because our specialist skills are better placed dealing with that sort of top tier of complexity. So that has been a challenge and will have continued to fuel the outbreak. So in summary, unprecedented rates of gonorrhea in Tayside, and you may expect to see more complicated or disseminated presentations in your clinical area. I know, how exciting. So do you have a low threshold for testing? They can have disseminated gonorrhea in the absence of urogenital symptoms. They can have DGI in the absence of reported high-risk sexual history, all right? The NAAT test has the best chance of diagnosis, but culture is important. And remember to test for all STIs if A, they're at risk, or B, have an STI. Ceftriaxone is still our first-line treatment, but for how long remains to be seen. There are exciting new prevention approaches on the horizon, and I think we need to look at reimagining and modernizing the delivery of sexual health care at all of its sort of strata of complexity in order to make it as accessible as possible. And that's us stamping out VD.
Thanks very much, Sarah. That was brilliant. I had my camera and my mic on mute, but you can be sure that I laughed at all your jokes, of course. And I look forward to catching up with Graham Leslie soon and hearing his details on all the extra manifestations of GC that you can get. But I'm not aware of many in the lung, so I think Professor Farden and I are okay, but maybe I can ask him. I won't ask you, that's putting you on the spot. That was brilliant and fascinating. I was struck, before we bring in other questions, that obviously there's lots of cases between the ages of 16 and 25, and you're doing, because a public health campaign is much on social media. It's funny when you speak to your kids, of course, nowadays they don't use Facebook, that's for old timers. They don't use Twitter, that's for old timers, but TikTok, Snapchat and all that. You know, are we focusing our public health campaigns in the right way?
This is a very good question. Let me see who's participating here to see if any of our public health people are here, because of course I follow our social media on the old people's platforms. I thought TikTok was only for dancing on, but I'm happy if there's a gonorrhea dance. There is a trichomonas dance because it has the the flagella in it. There's somebody here called GC, and I wonder if that's Graham Coburn, and if it is, are we on like TikTok and Snapchat and that? And if you don't want to talk, that's fine too. Or you can put it in the chat. I don't know. I'm not done with the kids. Oh, okay. GC's. Do you know? Wait, hang on. GC. Oh,
it's not the right GC, I'm afraid. Sorry.
Yeah.
Maybe Gary knows about TikTok. Who knows?
Right, hold on. I'll show you the dance. No, no, I don't know.
Okay, well, it's an interesting thought because, of course, it's about reaching the right people, and the older I get, the more I realise I'm not the young person I thought I was anymore. And it's
I don't know, but I trust them. So
okay. Got a question from Francis Travers in the chat. Why is data on women/AFAB limited in sexual health?
So because women, two reasons. One, lots of studies are done on MSM because they have high rates of infection. When it comes to HIV, we are very good at recruiting. Middle class, white, middle-aged men, and all of the studies seem to be those data. The problem with sexual health and women is our target population are also of reproductive age. often at risk of pregnancy, and women who are pregnant or at risk of pregnancy are often excluded from studies, and I think that's a real shame. I think there is an argument for protecting women and women at risk of pregnancy through research and not protecting them from research, which I think seems to be the angle. So yes, we get a lot of data from men. And engaging young people in research is also a challenge. Other key groups being racially minoritized groups as well. Again, a difficult group to access. But I think the reproductive risk, the pregnancy risk, is a big issue for within research ethics.
Thanks very much. I've got just a note from Christine Bird saying that public health are on Insta, but Graham and Adrian are on the case for other public health socials. That's interesting. Anna McDonald.
Hi, Sarah. Just about on that note, another argument, especially for in the wider kind of drug research against adding women or recruiting women, seems to be that women have a hormonal cycle that is 28 days, and that's too complicated to extrapolate, which I thought was really interesting, because one is you can actually ask women when they had the last period. And for me, the other one as well is we do want to use the drugs in women who have a cycle, which tend to be lots of them. So interesting comment.
It's actually really shocking, because then what we end up doing is extrapolating and use drugs less wisely in women without the data and actually put them at higher risk. Meanwhile, because we were trying to protect them from the research. So yeah, I think it's a minefield.
It's a really important point more widely. I think we were kind of lacking in lots of data in females. In lots of research areas. I'd have thought that it was interesting in your case, Melissa, you got the diagnosis from the knee aspirate on the NAAT, yes, I think in the other, yeah. But of course, there'll be lots of people who come in with swollen knees, get an aspirate with no history of arthritis, who would never have a NAAT tested. So do you think there are people out there who are coming in with swollen knees, getting an aspirate, nothing grows, off they go? What happens to those people? What's the natural history?
No, I don't know. I guess it depends what antimicrobials they get for. I don't know what you would give for septic arthritis, but the textbooks, and I did refer to my massive King Holmes textbook, that they talk about sort of if the history fits and they respond to anti-gonococcal treatment, then you can call it probable DGI. I think with NAAT tests, these are newer, and I think with the lab, I don't know if anyone from the lab, whether Amanda is on here, I'm just flicking through, or John Schoen, they were a little bit reluctant to do a NAAT test because it's not validated, and then what do you do with the result? But we know that the throat swabs and the rectal swabs weren't validated for ages, and we use them all the time anyway. So yes, I think people probably do, but I suspect the antibiotics for septic arthritis are fairly broad spectrum. I've got no idea what they use. Anyone?
Ceftriaxone, probably.
Yeah, yeah. Let's go with that.
And what would happen in the antibiotic era? People with disseminated gonococcal infections, what happened to them?
Was that, sorry, what?
In the pre-antibiotic era, people with DGI, what happened to them? You know, as a proportion would have dealt with it in the end, but long-term sequelae.
So if you just take gonorrhea without DGI, if you leave it long enough, 6 months, it'll clear up by itself usually. You might get what you would get for, you might die from septicemia. You can get endocarditis from disseminated gonorrhea. You can get meningitis. You might just get osteomyelitis, etc., and all of these things that could either progress or resolve with fibrosis and the rest of it. So yes, I haven't examined the textbooks for the natural history really of these things. But of course, in war times, we're talking about hundreds of thousands of hospital admissions, and so the in the pre-antibiotic era, or I suppose in the post-antibiotic era, we treat STIs probably inadvertently a lot, and so therefore the natural history has changed because of that. But yes, people were hospitalized with VD, so they may have had quite severe presentations.
Okay, thanks very much. Any other questions? And Kirsten, by the way,